It's been more than a year since the pandemic started. There is a global restlessness for human connection, with mask fatigue setting in and more people holding close gatherings. It's clear we are over COVID-19. The unfortunate reality is, COVID-19 is still here. We are not out of danger yet. In the past year, we have learned a lot about COVID-19. In fact, we are still learning. I would like to share information about what is known as long COVID. Long COVID is not limited to hospitalized patients, but affects even those who develop a mild or asymptomatic form of COVID-19. For more information, I spoke to experts in the field. All these interviews were conducted in January of 2021 during South Africa's second wave of COVID-19 infections. Hi, I'm Marissa Manech, and you're listening to the Woven Experiences podcast. Here we share stories around important topics and explore the interconnectedness between ourselves and the world around us. Let's get into it. Today we have three guests. We have Professor Lucille Blumberg, who is the Deputy Director of the NICD and Head of the Public Health Surveillance and Response Division in South Africa. We have Dr. Murray Dryden, who is part of the Emergency Outbreak Response Unit at the NICD. And we have Dr. Leigh Gordon, who specializes in sports medicine and is one of the three founding partners at Cape Sports Medicine. We will start things off and have a listen to what Prof Blumberg and Dr. Dryden have to share with regards to long COVID. And later, Dr. Gordon and I will talk about how long COVID has affected athletes and what they are trying to do about it. Welcome to Woven Experiences podcast. Today I'm joined by Professor Lucille Blumberg and Dr. Dryden. Let's start with the first question. What is long COVID? Dr. Dryden?
So let me just start by saying ultimately we don't really know what long COVID is and where it will go. Scientists all over the world are trying to extrapolate data from previous coronavirus outbreaks to try to help understand what we expect with regards to COVID-19. That being said, there is no currently universally accepted definition of long COVID, although the National Institute of Health and Care Excellence in the UK suggests the following definition. So for long COVID, in addition to clinical cases, the long COVID is commonly used to describe signs and symptoms that continue or develop after acute COVID. So this includes both ongoing symptomatic COVID-19 from 4 weeks to 12 weeks and post-COVID-19 syndrome, which is 12 weeks or more. And the generally accepted framework internationally that differentiates the differentiation between acute and post-acute infection is 28 days or 4 weeks. That being said, long COVID typical symptoms are remarkably wide. They can be a large variety, where the most common and prominent ones are severe fatigue, which is about 98% in one study of 3,000 people, as well as headache of 91%, followed by persistent coughing, shortness of breath, and anosmia, which is also a very interesting one, as well as a long line of other symptoms. So anosmia being the loss of smell, and then by extension, you can also have a loss of taste.
Who is most likely to develop post-acute COVID or chronic COVID-19?
With regards to incidence of long COVID, and those who become ill with SARS-CoV-2, preliminary data suggests that about 10% of patients are at risk of developing long COVID. When we look at those who are predisposed to long COVID, there's a wide spectrum of patients who may develop it. So disease severity has not been shown to be a reliable predictor of those who develop and who will not develop long COVID. And for example, patients who are completely asymptomatic are not automatically protected from developing long COVID, as well as those who develop severe COVID requiring significant medical intervention may not develop long COVID at all. We don't really have any concrete evidence that will accurately predict who will and who will not develop long COVID, although there are some studies that have identified clusters of symptoms which are associated with long-term symptoms, indicating a possible way of predicting early on what might occur. So, for example, patients who've had a persistent cough a hoarse voice, headache, diarrhea, they're skipping meals, shortness of breath within the first week of the acute infection, you are 2 to 3 times more likely to develop long-term symptoms than anyone else. In addition, patients who had pre-existing diagnosis of depression is also associated with more severe post-COVID fatigue, as well as there's data to suggest that women are twice as common to develop it compared to men, as well as a slight increase in patients who are overweight, but there isn't a significant number in terms of those patients. Patients who are elderly or have underlying comorbidities are also somewhat predisposed. Until we have the data for that, we can't say concrete what that is.
So pneumonia is a prominent complication of COVID-19. Does the long-term pathology of COVID-19 suggest that this effect can be reversed, or would it become a chronic disease?
So there's obviously a spectrum of acute COVID pneumonia. There are those who will respond quite quickly to oxygen and steroids. And then there are those who will unfortunately require other interventions, respiratory support of various kinds, from high flow oxygen to various supportive interventions to full ventilatory support. And there will be a proportion, and it's a relatively small proportion, who will have some lung scarring and fibrosis, and it's uncertain how this will resolve, and in some patients there may be more permanent effects. So various drugs have been suggested. There's very little work on this. These are drugs that have been used in other forms of pulmonary fibrosis, but we really don't know a lot about this in terms of COVID-19 and long-term effects, and how effective these drugs will be. So post-COVID, shortness of breath, reduced exercise tolerance are not uncommon and are a key feature of COVID-19. Many patients will recover, exercise tolerance can improve, and I think it's about, managing your exercise programs. And I think that's, an important discussion for runners and athletes. And I'm sure this is going to be answered by Dr. Gordon.
Of course. Now, another common problem present in COVID-19 patients are the formation of clots. What are the long-term effects?
Yeah, so we don't know. As you rightly say, clotting is an important component of acute COVID, and anticoagulants are widely used for patients who exhibit this problem. The majority will not have long-term problems and will not require long-term anticoagulation. I think it's very important that each case is evaluated individually, and this is an area where the physician will advise what is best for that particular patient. But it would be a small percentage of patients who would require longer-term anticoagulation.
All right. And multisystem inflammatory syndrome, that is actually mostly affects children, are now affecting adult COVID-19 patients. What long-term post-COVID effects would that entail?
So this multisystem COVID inflammation, as you correctly say, was first identified in children. It looks a bit more like a septicemia than the conventional COVID that we more commonly see. Certainly been seen in all age groups. It's not common, and we don't know yet what the long-term effects will be.
And the upcoming vaccines, will they prevent people from developing post-acute or chronic COVID-19?
Well, the vaccines are meant to be effective in preventing COVID. So, that obviously has an important relationship with the long-term effects. If you can reduce COVID infections, obviously you're going to reduce long COVID. And vaccines are an incredibly important component of COVID prevention. And I think we're still learning about efficacy, about safety, but to date the data is very promising. And it's really the way to go. We need to vaccinate people vaccine programs for many diseases have been highly effective in reducing occurrence of these viral infections.
And just for those who might not know or might not be aware, what current preventions can we take to ensure that we don't obviously get long COVID or any of that sort?
Well, both vaccines and preventing COVID infections will reduce the occurrence of chronic COVID. I mean, that's kind of obvious.
Yeah.
So what do we have? Countries are vaccinating, and hopefully we will join them soon in that intervention. But it's about reducing transmission. So it's and it's a story that people are getting fatigued about, but it's really important to apply these principles. So COVID is transmitted from the virus in the mouth or the nose. So cover your mouth and cover your nose with a good quality mask. It's a cloth mask for most people, or a surgical mask if you have that available, and wear it properly. This wearing of masks below the nostrils, around the neck, obviously they're not going to work because the virus is in the nose and in the mouth. So when you are in company, when you're in a confined space that you can't avoid, you must mask, and you must mask properly. Keeping a distance is important. I think 2 meters is what I would like to recommend. Good ventilation. Do whatever you can outside. It's crowded spaces with poor ventilation that are really the perfect setting for increased transmission. And we know that people are asymptomatic but are infected. So you don't know who's got COVID in your immediate surroundings. So everyone has to be responsible. Mask properly, keep a distance, good hygiene, sanitize, and as much as possible, be outside. Avoid crowds, and follow these rules. It's, family and friends are not always safe, and people think that's okay, but it's not always.
If someone had to develop long COVID, how would they manage it?
So patients should be reassured that the majority of symptoms will resolve with time. There will be, as Dr. Dryden has mentioned, those who have some troublesome symptoms or those that last longer than 6 to 8 weeks. But the focus is really on slow, stepwise rehabilitation and symptom alleviation. There's no specific therapy for long COVID. It's really about common sense extrapolations from other rehabilitation programs. So an individualized approach is best, based on the patient's symptoms and goals, and always taking into account the person's comorbidities. It's really a multidisciplinary approach, and it's really about being patient, about being kind to yourself. It's about embarking on stepwise increase in exercise, and it's really about a slow steps forward. So we're not talking about the athletes, I think, which will be addressed by somebody else, but it's really about, most of us who like to exercise and like to lead an active life. There are a number of breathing programs that can really help you to improve on that side, because shortness of breath and anxiety are real issues. People who lose their sense of smell can be introduced to these olfactory resensitization programs. I had a chef this morning who stepped down from his job because he couldn't smell and he couldn't taste, and we introduced him to an olfactory rehabilitation program, which I think has had some success, but again, one has to be patient and take small steps at a time. Who should seek further care? So the majority will get better, and extensive investigations are not necessary. Weight loss, I think, should require further investigation. People with comorbidities must ensure that these are managed optimally, so diabetes, hypertension, any other chronic medical conditions. We don't want to miss any underlying problems and attribute them to COVID. So if symptoms are very persistent, very troublesome, if there's weight loss, if there's anemia, these will require additional investigations. But for the majority, it's really about patience, kindness, one step at a time, and you will get better.
Wonderful.
I'd also like to just reiterate what Prof says. The most important thing is obviously you need to look after yourselves. Patients, I think, are very concerned. I think the way that the pandemic may have been broadcast to the general public has been a bit worrisome in terms of fear-mongering, if you could say that much. And patients who have had COVID, they need to appreciate the fact that they were sick and they were ill, and as Prof says, they just need to take it slow, and they'll eventually get back to the point. Everybody does eventually recover at some point or another, and it may take a few days, it may take a few weeks, it may take years, but ultimately the goal in hand is that you will recover. Obviously, the most important thing is starting slow when you start going again with regards to exercise and looking after yourself, eating healthily, as Prof said. But probably the most important thing with regards to preventing long COVID is not catching COVID in the first place. So hand washing, social distancing, and wearing a face mask are ultimately the most immediate goal that we have at hand. Once we get vaccination, then the process should slowly but surely come to a close, but we're a little bit away from that. So at the same time, we just need to be mindful of the fact that wearing a mask is highly beneficial. Washing your hands is very important. Social distancing is crucial. And we will get there. And slow rehabilitation with regards to the exercise intolerance and the fatigue, as well as headaches and other non-specific symptoms, as Prof said, with regards to loss of taste and smell, also very important things to address.
Yeah, I think depression, brain fog are quite, brain fog, people can't think quite clearly, are quite common. And COVID-19 can unmask underlying psychiatric problems, particularly depression. So those definitely need to be managed. You know, we have a lot of psychosocial issues anyway because of the impact of COVID without being infected with COVID, the virus. So, you know, these just add to the depression, the insomnia, fatigue, tiredness, fatigue with the world, I'm afraid, that patients experience. So, you know, psychosocial support, depression definitely need to be managed.
I think it is very important. It's, as Prof did say, 2020 was completely dominated by COVID-19. And I think quite a few patients, at least within the South African context, also had some of their non-communicable diseases. So diabetes, hypertension were sort of overlooked in terms of let's try and manage COVID. And I think they've somewhat lost sight of that. And it's very important, especially for clinicians, to still bear in mind that patients may presenting with symptoms that may be similar to COVID, but it may actually be attributed to another condition, which is important to look at. So it's a multidisciplinary team approach, and obviously the psychiatric symptoms are one of the things that we are seeing as that's being brought to light, but we're also diagnosing patients with newly diagnosed hypertension and diabetics purely because they've been admitted with COVID. So it is something we need to bear in mind.
And for people who present asymptomatic COVID-19 or mild COVID-19 or that are not hospitalized, but they later on they develop symptoms, how can a person determine whether they have developed post-COVID, and where can they find that type of help and support they might need?
Yeah, so that's a really interesting question and very important one. Given that, you know, there was so much COVID around, there are quite a large number of people who had mild COVID or were infected but asymptomatic, but did not have a laboratory confirmation. So the diagnosis of long COVID is not dependent on a confirmed laboratory diagnosis. I think if you had mild COVID and the symptoms were compatible, but you didn't have a laboratory test, and now you have this chronic fatigue, that is enough to consider long COVID. If you want to look back, there are antibody tests that may confirm that COVID infection was likely in the past. They're not always positive in those who've had COVID, but that is something that can be done. But you don't need a confirmed laboratory diagnosis, and in the presence of these kind of, quite typical symptoms to consider long COVID. Just be careful of people who lose weight, those who are anemic, those who have symptoms that are perhaps not common in long COVID. We don't want to miss other diseases.
All right. And where can they find help and support if they do struggle with these long COVID symptoms that they might not be familiar with?
So, this is always a difficult thing. Social media is something one needs to be just a little wary of. There's a lot of misinformation out there. There's a lot of fake news that you really don't want these people to take on board. I think there are a couple of websites that have got good information. Certainly, we've written, Murray and I and others have put together some, I think, good articles, www.nicd.ac.za. Your family doctor clinic, you may be able to get some help. I think many of the clinics are pretty overwhelmed, but your family physician is the first port of call if you are concerned. But it's not unusual to have this tired, this fatigue, this headache, bit of insomnia, cough from time to time, and intermittent shortness of breath post-COVID. I think when you need to be worried is if the shortness of breath is getting worse, if there's weight loss, then you absolutely need to consult your physician.
Well, thank you so much for your time, and all the best.
Thank you.
Thank you.
Yeah.
Long COVID has an effect on your physical and mental well-being. So how does it affect pro athletes that rely on their physical abilities? Welcome to the Woven Experiences podcast, Dr. Gordon. How are you?
I'm good, thank you this morning, Marissa, and you?
I'm good. So tell my listeners who might be unfamiliar about what you do or what you did before COVID came into the picture.
So I am a sports physician. So I'm a doctor who works mostly with athletes or with people who exercise, whether that be recreational exercise or professional exercise. So our practice is Cape Sports Medicine based at the Sports Science Institute in Newlands in Cape Town. And then I look after some professional rugby teams like Springbok Sevens. I also work for World Rugby and I volunteer for World Hockey, the FIH. So I wear various hats. But basically my interest is in looking after people who exercise and working out when they get injured and if they've got medical problems related to exercise.
So when did you decide, or how did you become interested in COVID-19?
So once everyone was in lockdown, there wasn't much to do other than watching the huge amounts of data flowing in every day, medical data. And after a few weeks, it became obvious that there were, other than the lung complications from COVID, that people that were hospitalized were having heart complications as well, which obviously made me concerned from an athlete perspective. So I kept a close eye on that, and I started keeping track of all the heart research that was coming out. And actually through lockdown and the next few months, I kind of compiled a summary and an approach to returning to exercise and sport. looking for the risks with, looking out for the risks of exercise and heart issues. And subsequent to that, there have been numerous publications about the safe return to exercise and to sport. And everyone's pretty much on the same page.
Well, you've just mentioned that there are a lot of heart complications with COVID-19, and some young people, including athletes, have developed myocarditis. Is it a common complication of COVID-19?
So the most common answer to most COVID questions is we don't know. So the problem is corona, the SARS-CoV-2 it's a new virus. So we have very little data, long-term data. So for our listeners, myocarditis is an inflammation of your heart muscle. So I usually explain to my patients that in the same way when you get a flu and you get all your muscle aches, that is because you've got some inflammation going on in your muscles. And that virus is sitting in your muscles, and that's what gives you those aches and pain, that backache and general body aches that you get. COVID is no different, and the issue is that we know that it can be sitting in your heart muscle, because your heart is made of muscles. So if you get inflammation in that heart muscle, then that is obviously a concern. So we don't know how common myocarditis is as a result of COVID. What we do know is that we kind of think about it in two different populations: those that have been hospitalized and those that haven't. Those that have been hospitalized, there's a lot more data. And what we do know in that population is that a significant proportion of people that have been hospitalized have got evidence of heart injury. And we see that when they do certain tests with enzymes. And what we know why that is relevant is because actually those people have a much higher risk of dying than the people who don't have heart injury. So that's for the in-hospital people. For the out-of-hospital people, obviously there's a lot less evidence. So there is some there are anecdotal reports coming out of the US about professional athletes who've had a cardiac arrest as a result of myocarditis. But the only studies that have been done so far in out-of-hospital patients show that there's a very definite risk of having heart injury and myocarditis. The interesting thing is now everyone's so interested in it, we actually don't know, we've got no control. So we're seeing the studies coming out, but we don't know how that compares to non-COVID viruses. So what we do know is there was a study of about, there have been two studies of athletes, in total about 48 athletes, of which 5 of them had myocarditis. So that's quite a high proportion. And that obviously focuses our concern on the safety of people returning to exercise.
So if I understand correctly from the American studies, that this can cause sudden death in athletes. Did I understand that correctly? Absolutely,
and that's a very unfortunate situation. So we know, even before COVID, we know that sudden cardiac death in athletes, myocarditis, is one of the significant causes. So it depends on which literature and which studies you look at, but anywhere between 8 and 10% of deaths in athletes under the age of 35 are as a result of myocarditis. So now that is, for example, you hear about people who've had the flu, then they go out for a run the next week, they finish their run, they get home, and then they either die in their bed and they're found the next morning. They're all terribly, terribly sad stories, because it's always a tragedy when a young person dies. And obviously, if it's preventable, then even more so. So, yes, and of the complications with myocarditis, you can get lots of symptoms, but unfortunately, sometimes the first symptom is a sudden cardiac arrest.
Wow. So for those who battle or have myocarditis, what is the long-term prognosis?
So usually, if we diagnose myocarditis in an athlete, they get overseen by a cardiologist, and that hopefully a sports cardiologist, and that cardiologist will keep an eye on them for between 3 and 6 months. And in those 3 and 6 months, we advise no exercise. And then they're monitored. So because basically what happens is you get that initial inflammation in your heart muscle, then it settles down and you get some changes like scarring, as you would with any injury. And the issue with that scarring is it gives you a higher risk of having abnormal heart rhythms. And if you have those abnormal heart rhythms, that puts you at risk of having a cardiac arrest. So the general consensus across the world for myocarditis is 3 to 6 months of no exercise. And once they introduced those guidelines, we saw a dramatic drop in deaths in athletes. So that was several years ago. And there's no reason why myocarditis from COVID-19 should be treated any differently. So I suppose the trick is actually to get to the diagnosis of myocarditis.
And then with that in mind, how long does it take for them to be able to start strenuous exercise again?
Now, are we talking about people with COVID or people with confirmed myocarditis?
I think with post-COVID patients, there's always across, they might not only have myocarditis, they might have other other complications from COVID-19. But for this purpose, I think let's focus on myocarditis. How long does it take for them to rehabilitate to be able to start strenuous exercise?
We do that gradually. And obviously, if not having trained for 3 to 6 months, you've lost a lot of fitness. So you have to start getting your fitness back. And then you have to monitor. So that's a very open-ended question, actually. And it depends on if there are any long-term complications from the myocarditis. Sometimes people can get something called a dilated cardiomyopathy, which is where your heart gets slightly bigger and the muscle becomes a bit lax and it doesn't pump as efficiently. So depending on if there are any complications, that will obviously take longer, but generally within a couple of months after returning to sport, you'd expect them to be back at full capacity. I think at this point, we need to talk about kind of diagnosing myocarditis and who would we be worried, which takes us back to if you've got someone with COVID, when should they exercise and when shouldn't they? So the guidelines are very, very clear that while you are symptomatic with COVID, you should not do any strenuous exercise whatsoever. And that goes for the first week after your symptoms have settled. So while you're symptomatic, no exercise. For a week thereafter, no exercise. And then you can slowly, gradually start exercise again. And it's when you start that exercise, if you've had any symptoms that would be suspicious for myocarditis, then you need to see your doctor and they'll need to do some more testing.
A lot of people I've come in contact with have had asymptomatic or mild COVID, but later on develop post-COVID symptoms. And how would they know if they have myocarditis?
So the asymptomatics are such an interesting group because there's a lot of stuff we don't know about COVID. So for asymptomatic patients, we would say no exercise for 14 days from your positive test. And then you can start gradually over a week, you can start increasing your intensity. The things that you are looking out for are chest pain, any excessive shortness of breath, because obviously if you've been off for 2 weeks, you might be slightly unfitter than you were before. Chest pain, shortness of breath, dizziness, palpitation, so where it feels like your heart skips a beat or drops a beat or goes in funny runs. And then also exercise intolerance. So we have lots of, obviously with lockdown, lots of people are doing home exercises and home fitness watches, and everyone knows what their heart rates are doing during exercise. If you see that your heart rate is going up disproportionately to your exertion, that is another red flag for us. So what we are starting to see lots of in the clinic post-COVID is people with exercise intolerance, and they feel fine otherwise, other than the fact that their heart rates are just much higher than it would usually be for the intensity that they run.
As I understand, you are part of a rehabilitation program for post-COVID patients with complications such as myocarditis.
We are, so most sports medicine practices will be offering post-COVID assessment. So essentially what we need, as you said beforehand, it's COVID doesn't just affect the heart, it's mostly a respiratory, so mostly a lung disease, but it can affect your heart, it can affect your endocrine system, so sugar levels, it can affect your neurological system, which is where you're losing your sense of taste and smell comes from, and there's some other interesting neurological things with severe headaches. And that's the other thing that we see in people who exercise post-COVID and suddenly get the most severe headaches when they're not used to it. That's another one of our flags. So we would assess these people. They'd come in, and really what we need to do is take a very good history from them to see what's normal for them and what is now abnormal. And then depending on that history, we'll determine which special investigations we do. And that might be blood tests, it might be ECGs, it might mean that they need to see a cardiologist for ultrasounds of your heart. And ultimately, there's a possibility that they might need something called a cardiac MRI scan. But really, those are limited for the people that have very definite symptoms suggestive of myocarditis.
Well, seeing as this is all relatively new, what has been your greatest challenge thus far?
The greatest challenge is for elite athletes, trying to rein them back, because they are just keen to get back training as soon as possible, and trying to limit them in terms of if they have got symptoms. Everyone wants to get back on the track, in the pool, into the gym, wherever as soon as possible, because they don't want to lose out. And obviously, this being an Olympic year, losing precious training time is really important. But the bottom line is it's your health and your long-term health versus the ability to train today. And we always look at things in terms of a risk-benefit ratio. And the thing is, if one is sick and one has symptoms, training is not going to have any benefit. It's only going to have risks. So we can talk about those risks, but essentially, if you're exercising with no benefit and risk, then one has to wonder why one's training. So I think my greatest challenge is educating the athletes in terms of why we have to limit them and what the potential outcomes are.
Well, I think we're all suffering from a bit of an existential crisis right now, not just the athletes. So just out of curiosity, how has rehabilitation been thus far? How has individuals been experiencing it, not just in a mental health capacity, but physically?
So mentally, let's start there. I think mental health has been massively affected by lockdown, by difference in training programs, differences in how to train, and all the social benefits that go on with exercise. So leaving that aside, from a rehab perspective, what we expect to see is, if I take you through a kind of, if someone comes in to see me and they have, if it's someone on a team and they've had COVID, but they've had, say, no symptoms, we'll wait their 14 days before, and we'll do a submaximal test on them. So we'll just do 15 minutes of cardio, either on the bike or on a treadmill, and we'll keep their heart rate under 60 to 70% of their max, and we'll keep track of their heart rate, their RPE, which is their rate of perceived exertion. So, if they're running really slowly, but they feel like they're running really hard, that's important. And then whether they get any symptoms. And then over the course of a week, we will slowly increase that intensity and the length every day. And each day we'll be watching to see if they develop any symptoms. and if their heart rate is appropriate for the intensity of exercise. Obviously, then if they start developing any symptoms, we need to investigate further. If we have someone who has got symptoms, then really if we know, say you have someone with, let's go, one of the things we are seeing actually is people who have exercise intolerance. So they come in, they've been running, they've noticed that their heart rate is way higher than it is ordinarily for what they do. We investigate them. All their investigations are completely normal. So we've got no structural reason for what is going on. But being that as it may, their response to exercise isn't what it should be. And in those people, they need to rest. You need to take things easy, and we do it week by week, and we see each week trying to see what their response is. So every single patient is individualized. There's no one size fits all for everyone. It's a question of at which point does your heart then start reacting normally to exercise. That's completely different to the people who've got known myocarditis, because, for those, if you've got abnormalities or funny palpitations and we pick up that you've got a funny heart rhythm, those people are then advised not to exercise. So, and then reviewed on a regular basis. And we need to work with cardiologists for that.
And for people who are not pro athletes or might not have the accessibility of these types of institutions, what kind of information would you like to convey to them with regards to post-COVID symptoms and exercise?
So I think the bottom line is the first thing is not to exercise while you have COVID, and not to exercise for at least a week afterwards. If you've been hospitalized, it's at least 2 weeks before you can think about exercising. So that's the first thing. No exercise during COVID, no exercise for a week after, and make it 2 weeks if you have been in hospital. If once you start, when you're going to go back to exercise, you're going to start at kind of 50%, and each day increase your intensity a little bit and watch out for symptoms. If you have any of those symptoms, you do need to see a doctor, whether it's a sports doctor or a GP or anyone. If out in the more rural areas, you do need to see a doctor, and those doctors will rule out that there's anything major going on. And sometimes if you don't have access to the more specialized investigations, then it's going to be a question of waiting to see for how long that settles. But essentially, you have to see a doctor to rule out the important complications, because if there is something that needs to be sorted out, it needs to be sorted out.
With athletes depending on sport events to make an income, a lot of them not able to participate, others not allowed to participate. How does that impact them, and what kind of impact will it have on our economy?
It has a huge input into economy. So I mean, COVID has very far-reaching consequences. I mean, even now we've seen in the last year the impact that it has. So obviously, let's start with professional sport. If you've got no professional sport or it's very limited, most sports gets its funding from broadcast rights. So if you are unable to participate, you're unable to broadcast, and therefore you lose that funding. So that's one of the major things. Then in terms of actual participation, it affects your ability to train, I guess, in terms of if you're depending on what your lockdown rules are. But I think long term, I'm concerned that with the massive surge that we are seeing in the second wave, that the sheer numbers of people who are infected, those people are going to be infected and affected by COVID in many ways. And one would hope that the second wave, although it seems to be a little bit more infectious, but we don't know so far if it is if it's as dangerous as the first wave. I think the hospitalizations and the deaths are similar, but it does seem that there are a lot more people that are have mild symptoms in the second wave. That's just kind of looking at it anecdotally from my perspective. But, what we do know from the studies that have come out is that even in people with mild symptoms, they can develop complications, and whether those are heart complications, lung complications, clotting issues, headaches with exercise, there's a huge range. So my concern is that we're going to have a lot of people with non-specific symptoms over the next year to 2 years. So, and we might not have answers for all of them.
Is there anything else you'd like to add?
No, I think really it's just a question of raising awareness of people that, it's if they're finding that they're not feeling the same when they exercise after they've had COVID, it's probably not in their head. It is a real thing. I think one of my patients was only too pleased to hear that actually it wasn't in her head. That there was something. She was like, I thought I was going mad. But when I reassured her to say, look, this is a thing. This is what's happening, and we're seeing it often. That actually was enough to reassure her and go a long way towards working with her to try and limit her exercise. So, I think it's being aware, raising awareness that people need to be aware, and that we need to get back to exercise, but we need to do it safely.
Well, thank you so much for your time, Doctor.
Thank you very much for the opportunity, Marissa.
COVID-19 has already had a huge impact on our economy, and the impact of long COVID will linger longer. The only proven method of limiting spread is social distancing and mask wearing. Please consult a doctor if you have any symptoms of COVID-19, and do not self-medicate using antibiotics and/or anti-inflammatory medications. Please note, antibiotics are only for bacterial infections, and COVID-19 is a virus. And thank you for joining me on the first episode of the second season of Woven Experiences. And that's a wrap. Thank you so much for tuning in to today's episode, and be sure to subscribe to this podcast to avoid missing out on any future episodes. I'd appreciate it if you could leave a review, and if you have any thoughts on today's episode or perhaps topics you would like me to touch on, you can contact me via email. A link is provided in the description. I hope today's episode provided some new insights to what it means to be human, and I hope to see you in the next one.